Hello everyone. Today I'll be giving you a very brief training on our coronary stent. So, our product is a coronary stent. What is a coronary stent? It's a medical device that is placed in coronary arteries. What are coronary arteries? Are the arteries in the heart that supplies the heart with oxygen and glucose. So, when do we use a stent? When there is a calcification or thrombus or atherosclerosis or atherosclerotic plaque in the coronary arteries. What does this calcification or atherosclerosis does in the arteries? It narrows the arteries, makes it narrower. That's why we place a stent to maintain the artery open in place. Okay, now we will get to our stent. Our stent is called everolimus. Okay, what does everolimus means? The evro comes from the drug name, which is everolimus. Everolimus is coming from the limus group, which is an immunosuppressant drug So most stents in the market, they have another drug which is called sirolimus, which is also from the limus group, which is also an immunosuppressant drug. But how does sirolimus is different from everolimus? First thing is everolimus is more lipophilic. What does lipophilic mean? So everolimus, number one, is more lipophilic. What does lipophilic means? Means it's fat loving. Lipo is fat, philic means attracted to fats. So this means it has a better chance to get into the cell membrane of the cells, because usually the cell membrane, if there is a cell, it's surrounded by a membrane, it's called cell membrane. Usually it's made of fatty acids, which is meaning it's made of fat. So to go into the cell, it is more lipophilic, so it has a higher chance entering into the cell. Next is higher bioavailability. What does this mean? This means there is more consistent drug levels in the tissue. So the amount of drug is consistent in the tissue compared to sirolimus, because it has a different lower bioavailability, so there is a different drug release profile. Next is faster endothelial healing. Faster endothelial healing. What does endothelial healing mean? Endothelium is the cells that lines the blood vessels or the arteries, which we earlier said it has a membrane, cell membrane. So this means everolimus have a better action at healing these cells, because usually there is a breakage of these cells that causes the issue. So when this heals, the problem reduces, reducing complications. Lastly is it have a better chance at reducing risk of thrombosis and restenosis. What does thrombosis and restenosis mean? Thrombosis means that the artery becomes occluded. Restenosis is, stenosing means blocked. Re means re-blocked, because sometimes if the patient does not follow a proper lifestyle modification, even after stent placement, let's say the stent maintains the heart blood vessel open, it still can get calcified. It still can get stenosed back. So 4 things, we talk about the everolimus drug. It's more lipophilic, have higher bioavailability, faster endothelial healing, and it reduces the risk of thrombosis and restenosis. So this is regarding the drug. How about the stent itself, the material of the stent? First, we are going to talk about that our stent is cobalt chromium. Cobalt chromium. Okay, it's made of cobalt chromium. Strut thickness is 65 microns. Is 65 microns. What does strut thickness means? This thickness. This. The thickness of the metal itself is 65 microns. So sometimes doctors can tell you there are some stents that are below 65 or below 60 microns. How is this an advantage? How is your 65 micron an advantage compared to this one? So what you say is below 60, studies have shown that the metal itself is not strong enough to withstand the pressure in the artery, so stenosis might happen again. Then we go to our drug release profile. Like we said earlier, it have higher bioavailability compared to sirolimus. It's very uniform in release, which means there is a consistent amount of the drug in the artery. So with 0 days of implantation, there is already 20% of drug release, and the drug continues to release for around 50 days after implantation. Okay, then we go to the design of the stent. We can call this an open cell design. What does open cell design is? We can see here that the stent has some windows. The stent is not a full-on metal. There are some windows. What's the advantage of the open cell design? All our arteries are not simply going straight like this. Sometimes there are branches that comes from the arteries. Let's say there is a lesion over here, and I want to place a stent over here, and I want to place a stent over this area. If I place a full-on stent metal, then this branch is affected. You can see that this branch is affected. The blood flow is gone. So what do we call, why is an open cell design is advantage? Because there is a side branch patency. What does this mean? That the side branch of the artery is still patent. because through the open cell design, through these windows, blood still can flow. So that's a very good advantage. Next, we go to the acute performance of a stent. This acute performance of the stent means, acute means short term, which means during the procedure, how is the performance of the stent? It's based on three things actually. 1, trackability. 2, pushability. 3, crossability. So what is trackability actually? Trackability is the ability of the stent delivery system to smoothly navigate through the arteries to reach to the target lesion. So trackability means that it ensures that the stent can reach to the lesion site effectively. Then pushability. Pushability is the ability of the delivery system to transmit the force from the operator's hand to the stent when advancing through the artery. So this means it ensures that there is enough or sufficient force is transmitted from the hands of the operator into the stent to advance it through the vessel. Lastly is crossability, which is the ability of the stent system to pass through tight or heavily calcified lesions in the coronary artery. This determines how well the stent can navigate through narrow or tight or obstructed lesions. So these are the three things that determines the performance of a stent. So you can always say that our stent has excellent trackability, effective lesion negotiation, perfect pushability and crossability. Lastly, we have two terms, which is after the placement of the stent in the artery. We have foreshortening and recoil. Foreshortening is the reduction in length. Recoil is the reduction in diameter. So as we can see here, foreshortening is nearly zero, so the change in length is nearly zero, and recoil is less than 5%. When I said earlier, it's perfect crossability, it's saying here crossing profile is 1.00 mm. This means if as small as 1 mm, it still can go through. And regarding the sizes of the stent, the diameter goes all the way from 2, increases by 0.25 all the way to 4.5. For length, 8, 13, 16, 20, and so on until 47. Most of the stents in the market goes up to 40 or 44, but 47 we go up to 47. How this could be an advantage? Sometimes we have an artery that has 2 lesions and might require 2 separate stents. However, this is a very cost-effective thing where I can only place 1 stent and cover both lesions. Or sometimes 1 lesion that is actually huge. I don't have to place 2 stents. 1 is enough. I hope this explains everything. And if you need any more thing, or any other questions, please do let me know. But this is more than enough, actually, more than enough to be able to introduce this to your doctors, to your interventional cardiologists, and hopefully provide us with good sales.